events. So, yes, do not swear, you're live on air. So even though it gets annoying, do try and keep your language clean. That's my Davina McCall moment. Right, so basically it's the debate. I'll outline the format for you. So the debate is the title, we should stop using the labels relapsing remitting, primary progressive and secondary progressive multiple sclerosis. I'm reading the title very carefully in case the debaters are going to dissect it in some clever way, but that's the exact form of words that we're going. So what are we going to have? We have 4 speakers. Unlike previous years that this has been done in the interest of PPI, we have an academic or clinical researcher and we have a person who's living with MS. To avoid it being too much conflict, there's one each side, so we haven't set it up that it's PPI versus the researchers, which might be fun for next year. And so you don't get just to vote for one side or the other. You have to listen very carefully to what both say. So that's the idea. The motion was identified and agreed by the steering committee as being probably one of the most live issues that we have in MS at the minute and moving forward. So hope this is a really important topic that you'll get to think about. Now, when it comes to voting, you get to vote before and then you get to vote afterwards. Okay? And the person that wins the debate is not the person that wins the final vote. It's the team that changed the most opinions. Okay? So we vote on the swing, not the final result. Okay? Which on a day where voting and elections are high in everyone's mind, we'll just get the rules very clear. Okay? You cannot ask questions, okay, out loud. All questions are done through the Slido app, so if you don't have it, download it very quickly. Appearing there, okay, so www.sly.do or slido, depending on your pronunciation, and the code is the #MS Frontiers. So that is when you put your votes in before and afterwards. That will be live and all the way through. What else do I need to tell you while you're getting there? So I will let you, hopefully while you're getting onto Slido and thinking about it, what you're going to put is your first impression when you hear those words. We should stop using the labels relapsing remitting, primary progressive and secondary progressive MS, is vote what you think of that. If you agree that we should stop, it's a yes. If you think we should keep on using them, it's a no. Now, here to try and change your minds, we have Dr. Tarunya Arun, who is a consultant and researcher from Coventry in Warwickshire. We have against her on the academic side, Will Brown, who's a consultant neurologist and researcher from the University of Cambridge, and also visiting the Clinical Outcomes Research Unit in the University of Melbourne. And then on the people living with MS, we have Dominic, who's at MS for 28 years. And seeing as he's come to do this today, I'll give him a promo that he has a self-funded or community-funded? Self-funded
right now.
YouTube channel, themsguide.com, which has 1,100 subscribers, and that would be quite nice if we get that to 1,400 by the end of today. That would help him greatly, so make his trip to Swansea worthwhile. And then we have Rabia Kuhn, who I think many of you have heard in the last session, who's again another person living with MS, who is a stand-up comedian at the Brighton and Camden Fringe she's performed. I don't like fringe festivals, they remind me of what I've lost. However, she also has a podcast, and being an American, it's the Bangs Festival. But anyway, that is your team. Has everyone voted? Has our first vote gone through? So, how are we? Are we there?
Just to add as well, if you want to submit questions, you can do that through Slido,
yes,
and they'll come through.
I got to go through that. I was introducing Slido. That's the only way you can ask questions as well. Whether you come. And can people at home do Slido as well?
Yes. Yeah.
Okay, so all the little people out there in the dark, you can also vote on this if you like. And how much longer are we going to give them?
I mean, we've got 88 people that have voted. So
okay, so there you go. Get your vote in now, and we will look to see what the temperature of the room is before our speakers come to confuse you.
Vote yes.
Be coming up straight away. Sorry, everyone. Bear with me a minute. Stop presenting to display the poll on this slide.
Good. Are we? No.
Oh my goodness.
Yeah.
It's my first technical issue.
I could do my beatbox version of the countdown theme tune.
Da-da,
da-da. That's kind of like a...
really small on my
It's
screen.
nothing great. It's just like... Oh, are we there?
I've got it on my screen, so I can tell you out loud.
Okay, so...
I can plug my screen in, can't I? Look. This is our first technical issue of the day.
So while it's... I can tell you that people did agree... That, so generally we are stoppers. So 61% think we should stop.
Oh no. This isn't better. Okay, this isn't working.
Yeah.
So, just get you to read the numbers.
Yeah, in the words of Adele, hello from the other side. That was so 61% agree, 39% disagree. Okay, so who's our agreeers? That is Tarunia and Dominic are agree, so you have everything to lose. Okay, and we'll go across, right? Away you go.
Martin, thank you. Thank you very much. Thank you to the MS Society, first of all. I think this is a topic which is completely, in my heart, and actually having the opportunity here to come and speak and debate and discuss this topic. 2 years ago, in the middle of a pandemic, I wouldn't have imagined that I'd be here with a patient who would complement kind of my discussion and my debate today. As my slides come up, should we stop labeling relapsing remitting primary progressive and secondary progressive MS? My answer to that is yes. And I think the answer from a lot of you looking at that score is also yes, but I think hopefully by the end of our discussions, you'd have decided that it is a yes. So if we go back to the very first descriptions of MS Clinical Descriptors in 1996, which was years ago, I'd like to sort of stress that. The clinical descriptors were really what clinical subtypes people saw in clinic, so relapse remitting, primary progressive, secondary progressive. And these then very quickly got adopted into clinical practice and then also utilized into clinical trials. Then in 2012, this group of people who came up with a Lublin classification thought that we must use the imaging and the biomarker data, which we've already got since 1996, and change the classification slightly. And then, of course, you have the Lublin classification, which divided people into two broad categories: people with attack onset MS and progressive MS. The difficulty with this is that there's a very hard line right in the middle, as you can see. The attack onset MS was then qualified by saying, are people active or people inactive? And then you have progressive MS, again, people active or inactive, presumably based on the MRI data. Now, our question here today is this fit for purpose in 2022? So there are a number of reasons why it's not. First of all, I think we all know that the clinical descriptors, to some extent, for a lot of us sitting in clinic, has actually changed. So we know that MS people can have relapses and not worsen, so there's relapse without worsening, and then there's people who get worse after relapse, so there's a relapse-associated worsening. And of course, as we are beginning to recognize more and more, there's also the concept of the smoldering, or patients essentially having progression, which is completely not connected to relapses at all. So I think the definitions are already changing among the patients we see. So this is the Tysabri or extension study, which is the post-marketing study, which looked at the TOPS observational program. So this is essentially, so as we all know, Tysabri is a very powerful drug. So most people who are on Tysabri achieve NIDA within 12 months, or at 12 months. So really, in this observational study, what really came into light was that at 5 years into the study, 37% of patients were progressing. And what was really worrying was that 2/3 of these patients were progressing, not because of their relapses, because they had progression independent of relapses. So I just want you to bear that in mind. Again, further studies, you have the OPERA study, which essentially looked at ocrelizumab versus interferon beta, which is an active comparator. So we all know interferon reduces relapses by about 30%. And actually, in this particular study, the progression, so disability or worsening independent of relapses, was 78% for the interferon group. And actually, if you look at the ocrelizumab group, it was 88%. So a drug which is kind of supposed to be stronger at reducing relapses. People were still having a degree of progression which was unrelated to relapses. So this is trial data, but what about other aspects of the disease? So we essentially know that if you look at people with radiologically isolated syndrome, people before their first clinical symptom even starts, they've essentially started to lose brain. So this is a very early study. So this is a Brazilian study which essentially looked at what happens in people's brains in radiologically isolated syndrome, and essentially found that people's grey matter was already, people with radiologically isolated syndrome already lost grey matter when compared to their control population. This again, reiterated again, this is a Magnum study. As you know, Magnum is a large MRI MS group, which actually forms a lot of the sort of the guidelines which we know as it is in the MRI world. And this was essentially the brain atrophy rates across the different MS subtypes. So whether it's clinically isolated, secondary progressive, relapsing remitting, primary progressive, and actually you can take it one step forward, looking at that previous slide, and actually take it to the radiologically isolated syndrome group. Everyone's losing brain, and everyone's actually losing brain at pretty much the same rate. So this artificial distinction, or the two-way system as we know it, which is the inflammatory group, which people actually start as this active inflammatory initial pathology and then progressing to this neurodegenerative progressive component. There are a number of reasons why the theory probably is not right. So one of the reasons is that if you look at pathology, so this was a very large study which essentially looked at very carefully looking at inflammation and axonal degeneration together in a huge group of MS patients. And they essentially found that irrespective of when you actually study these patients, the active inflammatory component of cells was equal among patients with relapsing remitting, active relapsing component, and the secondary progressive and primary progressive component. So really there is, the theory that active inflammation settles down, yes it does, but then perhaps it's got other things to do with it. This is a Brazilian study. Again, looking at what the impact of cognitive performance was on patients who basically had, who went on and developed MS. So this is the school grades of people who historically, who then went on to have their first episode of MS. As you can see from the second slide, the grade point averages for someone who basically goes on and develops MS, or the graph on the right, is essentially much lower when compared to, when they're sent for people who go on and have MS. Again, the graph on the left says that people who are in grade 3 probably had more brain than people in grade 5. So people are starting to have cognitive impairment years before their diagnosis with MS. Healthcare utilization data, you've seen this again. Previously, this essentially tells you that people, before their first clinical event, are already going and having prescriptions sorted out, having hospital admissions, having repeated visits to their GPs and physician claims, and it's not a small population, it's a huge population. So really, so the first clinical episode perhaps is way too late in that diagnosis. So what's the evidence which essentially says progressive and relapsing remitting MS are distinct conditions? Unfortunately, there's none. So this is the imaging data. So if you look at imaging data, so there's lots around there. But if you look at the imaging data of these people with primary progressive MS, so this is a study which was conducted looking at early primary progressive MS patients, serially followed up on a monthly basis. So people were essentially having scans every month. So at baseline, early PPMS patients already have 40% lesions. At 6 months, when you counted the lesions again, 30% continue to have lesions, and people continue to have active MRIs or enhancing lesions all through that period. So, and these enhancing lesions, whether they be the volume or the duration, were all similarly reported among the relapsing remitting and the secondary progressive population, really again reiterating those differences. Now again, coming back to the sort of the artificial divide between the acute phase, early inflammatory phase, and the neurodegenerative phase. This is a post-mortem study counting a huge number of brain lesions, so over 7,000 brain lesions in over 182 MS post-mortem cases. The mean disease duration was about 30 years. So when this study was essentially looked at, patients with the longest disease duration had a mixture of active and inactive lesions. And even the late phases, or the terminal phases of the disease, there was still quite a lot of activity to go on the basis of their post-mortem pathological studies. Genetic differences, again, none. So the number of studies, and this is a study which essentially looked at a multi-generational family study, looking at what are the differences between people actually having genetic differences in their phenotypes. And actually, in patients within the same family who had different subtypes of MS, they were no different among the progressive population when compared to the unrelated people who were then studied within that particular group. So to finish off in the next couple of slides, I really think thinking about MS compared to the 1996 and then 2016, 2013 classification is pretty outdated, really. We know for sure that there is a difference in these people looking at the way treatments have been licensed. But then there are also a number of similarities. Are we missing the boat with age, for example? We all know that brain shrinks with age. We know people with MS have got brains which shrink with age faster. So really, are we missing the boat with essentially missing an entire group of people? For example, if you look at that graph there, people with a very good brain reserve at the bottom of the graph, people with less brain reserve at the top of the graph. So somebody who has a poor brain reserve probably goes through this path in a very unbuffered fashion. So going from radiologically isolated syndrome to clinically isolated syndrome to relapse remitting secondary progression really fast. Whereas the person right at the bottom of the graph probably is the person who has got very good brain reserve, who probably skips through the relapsing remitting phase of MS or doesn't manifest it themselves in the relapsing remitting. And only when their brain reserve drops to a particular limit, they probably have the progressive form. So that is, there are a number of things to consider. So really, very important. So this is, I think, the real top line sort of information really. So 2022, and that's the chain of drugs which we've basically got, which is great. So for a drug which is a disease which is incurable, we've got lots. But this is the situation. So we've essentially got 2 drugs licensed for progressive MS. There must be a reason for that. And then it's a one-way system. So essentially, you know, as we were hearing this morning, we sit here as clinicians, sometimes very worried to deliver a diagnosis of secondary progressive MS because we know that this is going to be the end of the path for that patient. And I don't think that should be the case. We need to relook at this. So what I'd like to conclude by saying is that I think the labeling classification is outdated. What should be used as the benchmark is something, you know, we're here to talk about it. We really think that there isn't much genetic, there's no genetic, immunological, or pathological data which supports these differences. And I think the treatments which we give are arbitrary. So we essentially sort of, you know, targeting people. And the focus should then be next on pathology, should be on brain health. Features which we are completely missing the boat with if we concentrate on these divisions. I think that was all I was going to say. Thank you very much.
Right, so starting the counterattack, Dr. Brown.
This is not perhaps the side of the argument Rabia and I would have chosen. Initially. So this has been an enormous pleasure to prepare for, and that's because Rabia and I have sat down and said, well, what's been her story? And how have labels contributed or been detrimental to her story? And then we tried to fit the science around that. So rather than me presenting the science, actually Rabia is going to present the story and the science and trials that go with it instead.
Okay, so you guys know the premise, right? We should stop using labels, the labels relapsing remitting, primary progressive, and secondary progressive MS. So our answer, unsurprisingly, is no, we shouldn't. They were yes. We think that stopping entirely would actually cause harm, and we think modifying and adapting is what we recommend. So first of all, my story. I was diagnosed around age 20. I know it's hard to believe. At the end of the line, it's 43. That's been 20 years. And yes, I am 43. People ask me. So after I was diagnosed, I went on Copaxone pretty quickly. It was a daily injection. I stayed on it for 4 years. For me, it wasn't the right thing eventually. I got tired of the daily injections, to be honest with you. Tysabri was available. Now, keep in mind, I was in the United States. The qualifications for getting prescribed any kind of medication there are a lot different than here. And so Tysabri was available. I took that for 2 years. It was not available to me anymore because of the antibodies that I have. So I had a relapse after I went off Tysabri a little while after that, and I went back on Copaxone for a bit, and then I suspended DMTs. and I woke up about 5 months ago with optic neuritis and a likely relapse. We're still investigating that. That's been my story. I want to say very clearly, having relapsing and remitting MS gives me a different story than a lot of people. And so I'm talking about it from my view. So without labels, though, I wouldn't have been informed to plan. There was a lot of planning I had to do. I understood the progression, the expected progression of my relapsing remitting MS, though it has surprised me here and there, but I knew there was a certain progression. I was able to make informed decisions about treatment and about future planning. I was able to even plan to move here for a while, actually, here being actually to London, not to Wales, specifically. Just made that mistake once already, saying that. But I was also able to decide about different things in my career and different things I wanted to do. Now, this slide makes me uncomfortable talking about just because, again, from my view with RRMS, but basically what it's saying is the prognosis of being impacted, like from a disability perspective or from mobility perspective. For someone with relapsing remitting MS, there's like a longer runway than for progressive. But for me, what this really says is that we just need to work harder to get treatments for people with the progressive forms of MS, because it seems like a lot of them are just for RRMS, and I'm learning more and more at this conference too about what that means for progressive MS. But I don't think taking the labels away will really help that. Without labels, another thing I wouldn't have had access to really are treatments. Like I said, I had Copaxone right when I got it, then Tysabri, and then just without knowing their effectiveness, I probably wouldn't have made a decision to even go on any medication. And I understand I said I'm off of DMTs now, but I also made that decision with a doctor who disagreed with me, but who also understood where I was coming from. And now I'll be able to make a decision again when I qualify, or if I qualify for DMTs here. Now, in looking at a Tysabri trial that took place, there was evidence that there was a 42% risk reduction with mobility issues for people with MS who have relapsing remitting MS. But in secondary progressive, there was no observable difference. Now, there's an asterisk there. That's because we looked at those two studies and looked at the measure that was the same. There were a lot of other ones that indicated also that it could help people with secondary progressive MS, but we're looking at the like for like in this. So again, just to conclude, in my case, the labels impacted like me, getting treatments that were identified and that were licensed and then prescribed to me. So again, the labels aren't perfect, but just fully stopping their usage would end all of their benefits, and there are some. But if we adapt and modify them, then we can take care of the ways that they're harming people, perhaps, and the harm that they're causing, but also continue to use them for good. And science is adapting and modifying our views, our understandings of things, and so just eliminating something outright could be harmful. So that's it for us.
Splendid, which now leads me to the sort of just calling someone up and not being quite sure who's going to come. But I think it's Dominic next, and I think you're going to talk again, hopefully.
Can you all hear me? I don't like standing behind a lecture.
Can you please stand behind for the live transcription? We need
I beg your pardon?
For the live
Oh, okay,
stream.
okay.
Okay.
Thank you.
And have you slides?
No.
That was wonderful. I can see why they switched it up, because they don't have a leg to stand on. So it was a jolly good try, I'd say. And I really particularly like the way you swerved to doing anything well. And I just think there's a danger in campaigns that you focus on fighting the last war and not the next one. And this is what we have a case of here. You all know that these are confected categories that were required, to get orphan drug status, to get beta interferon licensed back in the late 80s, the early 90s. So it was a complete confection of the drug companies because they needed to be able to show efficacy and they needed ODS rather, to get it. So it's really turned into a double-edged sword, all unintended consequences. I mean, there is, I would say, one good thing. I was trying to think about this. A medication got licensed. It was the first one I got to take. And it opened the floodgates. What do we have now? 13, 14 that are theoretically available to use? Well, no. Theoretically available to use for some people with MS. Because these confected categories, these commercially necessary categories that came about and now have become dogma, and every patient wants to know where they fit, you know, serve to deny some people the ability to get drugs. Because you may get a patient that's, say, on the borderline, and Klaus says, well, they're this, and Emma says they're that, and at the stroke of a pen, that patient may be denied some effective medication. I'll give you 2 examples. I was thinking, these are case studies. I've spoken, friends of mine, I've got their permission. Before anybody freaks out that I'm going to start. Adam is 46. He was diagnosed in 2016. He's got a really good job. He's an economic contributor. He has a wife, he has kids, he has an active life. And somebody said from day one, you're primary progressive, mate. There were no drugs. He's a bright guy. He's got an income. He's spending a fortune on private medicine, low-dose naltrexone. God, I can't even remember now. It's so late in the day, and my 28 years of MS has cooked my head. But testosterone, that was it. Adam takes testosterone too. The worst that you can see with Adam is he has a stick sometimes. He plays paddle tennis. He swims. He cycles. He does all these things. Yet he cannot have a drug because somebody said primary progressive, end of story, mate. As opposed to say, as I spoke to one neurologist who said, I like to read MRIs in a darkened room when I squint hard. It gives me a lot of leeway. You know, but essentially, the second patient, the opposite side of this, who hasn't been affected by these categories, is my friend Kathleen. She's 71, and she was diagnosed when she was 50. And her treatment team said to her from the outset, we don't like categories. We're not going to lump you into something. We're going to treat you as a patient. We're going to treat you holistically. And the mental comfort that she got from knowing that her treatment team was looking at her as an individual, and she was getting this wraparound holistic MS care from cradle to grave, and she started on Copaxone, and then she went on to Magolimod, and at 70, maybe not everyone will agree with this, she was given cladribine. You know, she said it's her last shake. You know, I had Lemtrada the other day, well, a little while ago, but it's my last shake too, you know, but it's just now I don't care what anyone calls me, you know, relapsing, remitting, I don't care, you know, but I got the drugs I needed. But somebody like Adam, now he can get ocrelizumab, but he couldn't. So if you think about this debate, and it was nice to try it, subverting it, guys, but if you think about this, when you vote, either you're going to vote for this sort of dogmatic, anachronistic old system that was put in place to serve a commercial need, or you're going to vote because you all know, I'm not allowed to swear, darn well, that MS is this continuum, essentially, and having to draw the line and say somebody fits here, but they're not there yet, is a very difficult thing to do, and it can be quite damaging to people. So this debate, if you think back to it, is not about the individual, my dear friend Rabia. It's not about a person. It's about whether or not you change your vote. And if you choose to change your vote from the 60-odd% that voted in favor, you're essentially saying it's fine to disadvantage patients. Knock yourself out. So that's what I want you to think about, is when you come to vote, is do you think that actually patients need to be kept in one of 3 boxes? Thank you very much.
So following that, no hint of emotional blackmail. Someone from the other side, I don't know, is one of you going to come up for your other 4 minutes? Come on.
So I'd just like to clarify that I don't disagree with any of that. I thought both of those talks from Dominic and Tarinya were amazing, and both the science and the just horrendous effects that these labels have had do mean they need changing. But that is not the debate. So I'm going to continue using Rabia's story and the points that have come out of it about where labels have been helpful to say, how about in one of the new classifications? And so I'm going to use what I think is the state of the art. This is Armin Ishaghi's paper. I'm really sorry he's not here. This has been presented multiple times at Frontiers already. And just to kind of take you through it, I'm going to go through it in a bit of depth so everyone's on board with it. Armin threw more than 30,000 MRI scans at a computer and said, what are the abnormalities here in people with MS? And find them compared to people who scans which don't of people who don't have MS. And he took the computer, said, right, here are 13 abnormalities. At which point Armin said, fine, I'm not going to tell you what the label is. You can reclassify MS based on the MRI. And that's exactly what happened. That actually he found that there are 3 subtypes, and I say he, this enormous collaboration of people found there were 3 subtypes. And those subtypes suggest that they are reflecting different mechanisms, and that is really attractive. So the first one is in people where the outer part of the brain, the cortex, begins to shrink first. So we call that the cortex lead. Then on come the lesions, which is here-ish. And then later on, the tissue around the lesions becomes abnormal. That is the normal appearing tissue. That's category 1. Category 2 are those where the normal appearing tissue is abnormal first. And category 3 are what we kind of all think about when we think of an MRI scan from someone with MS. Lesions. Lesions getting worse, and then on come the other abnormalities. Does this have any relevance clinically? Yeah. So when they restricted their analysis just to trials of people with progressive MS who had been, and those trials were using drugs that we know have an effect, people in the lesion-led group, so the blue ones, they had a 66% slower rate of disability compared to those who are on placebo. That's unheard of. That's enormous. It's much bigger than using the old classification. And when they limited it to trials with people with relapsing remitting MS, it was an even bigger effect. So this is massively going against my argument. This is really good. But what about outside of treatment? Well, again, yes, this new MRI classification enables the distinction of or ability to predict how disability changes over only 2 years. That is really hard to do. And when they compared that to using the old labels that I'm trying to defend, it didn't work. So why am I presenting this? It's totally against my narrative. Well, it's for 2 reasons. The first is that when they then added the labels, these terrible old labels that are so awful, it improved things further. And that's the point. We're not debating whether to sort of modify things or switch things. This debate is saying stop using the labels. And here, in what to me is the best new classification, when that happens, you can make it even better using those old labels. So, kind of in summary, these new classifications look great. They're much more based on what's actually happening in the, at a kind of pathological level. And, I've just shown the evidence suggesting they can distinguish people who respond well to immunotherapies. But it's not a stretch to suggest that these might be really useful for figuring out who might benefit from a neuroprotectant or from a remyelinating agent. So this is great. but they are not ready for clinical use. These have only been examined largely in trial data. No one with less than 3 years of disease duration went into this. So the suggestion is that if we use this and we say to someone, I think you're in the lesion-led group, but we're going to wait 3 years because actually we can't say that for sure. So we've got to look earlier on. No spinal MRI was included here, which is a frequent event in people with MS. And of course, it doesn't include things like neurofilament. And of course, the beauty of the old system, as inaccurate as it is that you don't need an MRI. You can make the distinction using the story. And that's really important as a comparison. So in summary, should we stop using the labels? No, 2 reasons. One is no alternative is ready, and secondly, we should actually be combining them for the best accuracy. And just to prove this point, this is exactly what Rabia has said. We should be modifying our old classifications, and actually that's exactly what the lead author of this paper says too.
Thank you. Splendid. Good. Right, well, I would like to apologise for some very poor chairing and not holding people to time, but the talks were very good, and I hope you forgive me, because I think and hopefully that will save a little bit on the questions. So for people at home, we will try and get you away for the 6 o'clock news, because things have happened today. Right, so... Right, I suppose this goes to the people who are telling us to stop. So, for Turini or Dominic, is there any better way to describe the different types of MS? If we're going to stop it, you're not going to win the argument just by that. You've got to give us an alternative.
Yeah, sure. So, I mean, I think most conversations start at a point. Now, I do take Will's point in that. I don't think we're quite ready for prime time yet with these classifications and the MRI being kind of, the surrogates, taking away labels in that fashion. But really, I think we must start recognizing that the disease is not what we think it perhaps is. So there is a component of the disease which surely we are missing with looking at the way treatments have worked in different patient groups. So I think my answer to that is that no, at this point we're not. But unless we start thinking about it, we're never going to find a solution. So we're sat here 25, 27 years from the initial classification, still delivering these 3 subtypes to our patients in clinic. Not perhaps, I don't know how many people in this room can put their hand on their heart and say that they feel very comfortable about doing that at their clinic appointments. I certainly don't. I think that's something to sort of think about. So it's not ready for prime time yet, but perhaps it will be in another debate in a few years' time.
I hear a clever wiggle there in the document. You're saying you should stop, but you haven't actually said when. Okay, I think I heard that there. I'll just, yeah. Dominic?
Can I just say, Will said something very interesting. He said, this will improve things. And he never really followed up with for who or how. So just sticking with them because, it's a continuum. And given they were confected in the late 80s, early 90s, but now we want to stick with them because somebody made them up and now, it's our dogma. From a patient point of view, if a neurologist looked at a patient and said, you have MS, I have 14 drugs, the neurologist can do all the fancy things and you can look at the MRI and you can then pick the appropriate drug that you feel for that patient. But this whole concept of saying you're X, you're Y, you're A, therefore you may or you may not have certain drugs is just ludicrous. It's just, some clever person at NICE, I don't know, but it's,
Good.
I
Rabia,
guess it's better.
Can I challenge you a little bit? Okay, so one of our little people has come in to say, I'll get you can answer that one later. But Rabia, so you talked about how the labels had worked for you and made life good for you. Would you have felt the same if you'd had an adverse label, a primary progressive diagnosis in 2005? I suppose that's the same point Dominic's making here.
Probably not. And that was kind of why I tried to caveat that a couple times. And it didn't make life good for me. So I think that saying that is also damaging because I don't think we can look at anyone with MS and say, oh, they're lucky, or even out of this debate say, well, one of us is a winner, because two of us up here are living with MS right now, so I don't particularly feel that makes me a winner or makes me lucky. I feel very fortunate that I've had the opportunity to live in a certain way with MS, and that includes even being here and being able to talk about this, and the MS Society providing a place for patients to have a voice. But would I have felt the same? It's hard for me to say. I think it's always hard to be in someone else's shoes. I know that I have been scared a few times. I know I haven't been able to walk the way I wanted to a few times, and that scared me. And I don't know what it would be like to have primary progressive or secondary progressive, or to have no treatments. And so I don't have a good answer other than probably I would feel differently. But that doesn't take away from the fact that my answer remains the same, that we need to adapt and modify and use the information we have to change things. And if the fact is, if these labels are causing a government body to say people can't get treatment, then maybe that's where it needs to start too. Yeah.
Good. No, we've got, I think, a question that gets actually some of the points that Dominic's been making, and I'm going to leave it for him and turn you to answer, which is a little bit about drug licensing and what trials would look like. And to kind of expand on the question a little bit, obviously I know that if you tried some of our drugs in all patients with MS, they would be negative trials. We've got to enrich them, and actually these labels have worked very well. You mentioned some of the licensing things about enriching. How would we get trials, and how would we easily identify at least slightly homogeneous groups of MS patients for trials if we drop the labels? What does it mean for licensing?
Well, there's one thing about the labels, and I think Rabia made Rabia, sorry, I've got a friend called Rabia, made a good point about the fact that this is also, if you think about, we are now being hit around the head with these by NICE or something, and then you guys are being, in theory, limited to what you may or may not do when you see a patient who has a label, because if, my example, Adam came to you, he's already got the tag. You know, now, thankfully, he can have ocrelizumab, but you may feel that there's another more suitable drug for him, but that's out of the question, because you can't sort of get the genie back in the bottle. You know, he was given that primary progressive with a stroke of a pen in 2016, and that's life. You know, so I just think, you know, the classifications you talk about, MRI will and everything, but this debate is about, should we drop the use of these classifications, relapsing, remitting, secondary progressive, primary progressive, and I still think we should, because with the rest of the current system that surrounds them, that, you know, if the debate was about should we get rid of NICE or should we change the way NICE do things, that's different. But this, the result of these labels is being, should we say, beaten up as patients.
So, I mean, what I'd just perhaps like to add to this is, I don't think it's about taking away labels in a way that it would perhaps impact one group or the other group of patients in a negative way. But I think if you look at the disease as such, I think it makes common sense that if you've got an active disease, those patients should be suitable for a trial. So, for example, if you've got an active primary progressive, you've got active secondary progressive, and active relapsing remitting, they're all in the same category. So how can someone decide that these patients are hugely different when there isn't that research behind it? So there isn't that difference pathologically, there isn't that difference immunologically. So so my point really is that I think any active disease should perhaps be suitable or eligible for the treatments that we have available. So the problem with the trials at the moment is that this artificial division then completely takes out a bunch of people from getting into the trial who might have otherwise been active group of patients. So for example, an active PPMS patient is completely excluded from the relapsing remitting trials. So really there is at least 15 of those drugs have never been tested in a huge bunch of patients. So I think the classification, that's where the classification comes in as an impediment, and I think that's perhaps my point.
Yeah, there's a horrible consensus emerging, but there's a question that we just put that by, which maybe I'll just clarify. There's someone saying we're dropping relapsing, remitting, primary progressive, secondary progressive. Are we looking to drop active and inactive as well? But I think what you're saying is you like but you are kind of saying active, inactive, but you're not. Are you trying to re-dichotomize MS again into active and inactive, and therefore drop these? No.
So, I mean, yes, I think the activity, of course, has to be defined differently. I don't think we're saying stop these labels. We're not saying stop any label. I don't think we're ever going to be in a position where we're going to stop any label in MS. Because, as you say, there'll be a huge dilemma as to who you're going to put into trials if you stop every single label in MS. But I think what we need to start thinking about is the way we're labeling patients in clinic is very arbitrary. So I could do one thing, you could do another thing in clinic. And that could be, determine how someone might turn up in 20 years' time with their disability. And I think that's not right.
Okay, sorry, go ahead.
Active and inactive, that's pretty binary. Whereas it's like commenting, do you like that car? Well, that's a matter of taste. Was that car speeding? Well, that can be discerned. You're either doing 69 miles an hour or 71 miles an hour. Which is the active inactive lesion. Whether or not you like the car can vary between individuals.
Okay. And I'm going to, if I make the last question a topic to discuss rather than a question, so that both sides can maybe comment on it. But there is obviously MS, there's sub-communities within the MS community, and the progressive community have built up. They find a lot in common with each other. They have funding agreements that they've done. What would relabeling do to the progressive MS community who have felt neglected, who've got left out, and then if they're also kind of Plutoed and wake up next morning and find they're no longer a planet? What's the... relabeling and the progressive community, impact good or bad? I don't know, Rabia, do you want to start with this one? We've kind of...
Well, again, me speaking... Yeah, and it's just me speaking on behalf of a community I'm not part of is difficult. But I don't, so yeah, I don't know, I guess, and I'll still give a long answer even though I don't know. So I think probably, again, to me, and just looking at change management in general, and especially regarding people's health, because if you look at businesses with no change management, they fall apart, and I think with people's health too, if you're going to remove a label, and that's where they've arrived at a sense of self, and I certainly have, part of my sense of self is related to living with MS. I think there needs to be a replacement. So I don't know how to answer it without saying that I guess maybe for people, if you're part of a community, you're still part of a community. Maybe it'll expand. Maybe there will be more of an understanding between people, like we all have MS and some of us are impacted in different ways than others. And maybe there could even be some kind of more coming together, because I think the last question felt very pointed about relapsing remitting versus the progressive forms. But I think it's just a matter of then people continuing to meet or continuing to meet online or whatever they're doing and continue to fight for each other even if the label changes, because the circumstance of the life hasn't changed. Just if you told me tomorrow we're renaming multiple sclerosis to something else and I can't be clever enough to come up with something because we don't like the initials anymore, MS, I would still have something, and I would still find the group that was representing me and I would still fundraise for them and participate in everything else. So that's my answer. Yeah.
Do you want to come in on that from the other side?
This debate is about whether or not we should stop using the labels, not relabeling people. It's not suddenly yanking the carpet out from under a group going, you're no longer valid, you no longer have PPMS. It's going forward, when people sit in front of you, are you going to sit there and say this? I mean, I don't recall the words relabel being used in the debate, and I think it's a bit of a non-question because it strikes me slightly absurd. We are who we are. Like Rabia said, even if you stopped using the term MS, it wouldn't change the fact that we had it, and we wouldn't suddenly lose our identity and be completely rudderless and have no community and all this kind of stuff. So I feel it's a slightly off-topic question.
Good. Right. Okay. Going to wrap things up. We've got 1 minute each side. Will, I'm going to ask you to summarise your top points in 1 minute, and then Tarunya, you get to summarise 1 minute, and then everyone gets to vote again. Will, your 1 minute starts now.
I won't need a minute. So we're simply being asked, do we stop using the labels? And there's two very simple reasons why we do not stop using the labels, and that is because there is no validated alternative ready to go, and secondly, because they do allow us to see differences in efficacy of treatments. There are advantages there, but I entirely agree with everything that's been said by people to my left.
And Rudy, before people change their vote and go away, one last minute to convince them. Your best points.
Yeah, so I think we change everything with time, and why not this? Because 27 years with a label is, I think, a bit too long when we're here discussing research changing by the minute, but we still stick to these labels. And also, this is not about not treating MS. This is about treating MS the right way. So essentially, it's treating patients who are active with the right drugs. It's also looking at other aspects of the disease. What about brain health? What about looking at aging within the spectrum? So I think this just opens up. I think saying stop using labels does not mean stop doing anything. I mean, what it essentially means is that start looking at other things. And I think, it's time we did that as MS neurologists. And I think that was going to be my summary.
Thank you very much. Well, big thanks to all our speakers. Good. Right, so while we work the techniques to see who's won, can I just remind you all that the drinks and poster judging will begin at 6:15 in the galleries, which I think is that where we had lunch?
Yes.
Yes, that's this with a nice view, followed by the conference dinner, and there will be staff around in orange t-shirts to help you if you get lost. So, drum roll.
What I'm going to try and do is replug in my laptop. So you may see the otters again.
Good, and just to remind you that before the vote it was 61-4.
I'm going to get the pre-vote up.
Ah, we get to see our pre-vote.
So this is our pre-vote.
And the after?
Is everyone ready for the big reveal?
Oh! Will and Rabia, well done. I do love debates where someone that says, I don't believe in my topic, still manages to win. But I think, in case people go, I think there was so much agreement between the two sides that what we have is not right. But equally well, we might not be ready just to let it go yet. We've got to find something that involves the old labels but makes them better. Thank you very much. Drinks in 15 minutes.